सर आप कनेक्टेड सर आप कनेक्टेड है। हाँ जी। तो, हाँ जी हाँ जी। आप सर एक बार वीडियो ऑन करिए। AY. Today we have an important topic on radiochemotherapy in head and neck cancer, and I can guarantee you 99% chances that in the MS or DNB exam you're going to get one question on radiochemotherapy. So you should read this topic, you should attend thoroughly, and then go in exam. So before that, I want to invite our moderators for today's session. We have Dr. Arjun Das sir. Sir is ex-HOD of GMC Chandigarh. Sir is senior consultant and superannuated from GMC Chandigarh. Sir is now a leading practitioner at Chandigarh. Sir, please correct me if I'm wrong. You're working at Fortis in Chandigarh. No, sir. Sir, please unmute yourself, Arjun Das sir.
Max Hospital.
You're working at Max. Okay, great, sir. Welcome, sir. And our next moderator is Dr. Bhushan Kathuria. So he's a leading practitioner at Rohtak at V Care Hospital. He's a head and neck oncosurgeon. So I invite our today's speaker or the guest faculty, Dr. Shahrawat sir. Sir is a leading radiation oncologist. Welcome, sir. Now I invite you. Please, you can start the session, sir.
Okay.
Thank you. Thank you.
Good evening to all of you, and thanks for considering me for this important deliberation. One AY to another AY, that is American Oncology Institute to Association of Otorhinolaryngologists of India. इत्तेफाक की बात है कि दोनों AY हैं. So most important thing I want to convey is that head and neck cancer treatment is a multi-modality treatment. The surgeons and the radiation oncologists have to join hands, and if they do not join hands and they keep blaming each other, then this is what will happen. So I will go back once again, and you see, if they join hands, they are so happy. And if they keep fighting that, no, this is my case, this should not be treated with surgery or not with radiation, then this is what is going to happen. So the most important thing in treatment of head and neck cancers is a good understanding between a radiation oncologist and a surgical oncologist. Radiotherapy has never been a part of MBBS topics. So in MBBS, we hardly come to know what is radiotherapy. We just know about cancer, its treatment, but no visit is made to the department. So I'll just give a brief of radiotherapy. It is of two kinds, teletherapy and brachytherapy. This is the teletherapy machine. Teletherapy means from a distance. Tele means from a distance, like telescope, television. So teletherapy. Like the patient will lie down on this couch and external radiation will be delivered from above. In yesteryears, the machine for teletherapy was cobalt-60 machine. Nowadays, we have got linear accelerators in which we deliver radiation with photon beams and electron beams. The other part of radiotherapy is brachytherapy, in which we introduce the radioactive isotopes inside the interstitium of the tumor. So in coming slides, I will show you the examples for better understanding. So this is a medical linear accelerator. This is the one which has been installed at American Oncology Institute, Gurgaon. Whenever a patient of head and neck receives treatment, this is one Orfit cast, thermoplastic Orfit cast, which is prepared for every patient. Patient wears this and lies down. It ensures reproducibility of treatment in every fraction, and it also ensures immobilization during treatment. So it maintains accuracy. It is millimeter to millimeter precision. So this is one radiotherapy technologist setting up the patient on the couch, and there is perfect matching with the help of lasers on beam. So this is the final position in which patient will be there. And nowadays we have rapid arc technology or volumetric modulated arc therapy. Like the patient lies down on the couch, that box is, say for example, head of the patient. and the gantry of the machine is rotating. So it is capable of rotating all 360 degrees. As you can see over here, the patient will receive treatment for about 8 to 10 minutes. The patient does not feel any heat or cold or any pain. So this is as simple as that. Talking about mechanism of action, basically the radiotherapy by different mechanisms, it damages the DNA strands. So as a result of that, it is a non-repairable damage. And when the cells multiply, say for example, in a month's time, they undergo multiplication. So when the time for multiplication will come, the cells will not be able to multiply and thereby leading to death of the cancer cell. This is precisely the reason when we complete a course of radiation for head and neck patient, we do the response evaluation at 3 months post radiation. So by that time, all the cells might have been killed. Now, before talking about the radiotherapy and other things in detail, we need to understand three important terms. One is definitive treatment, another is adjuvant radiotherapy, another is neoadjuvant treatment. Definitive treatment means, say for example, I take up a case of CA base of the tongue. I have to treat with definitive intent in order to cure him. That will be radical intent also. I will treat with 70 gray in 35 fractions with the intent of curing that patient. So this is definitive treatment. I may add concomitant chemotherapy in this. Another term is adjuvant radiotherapy or post-operative radiotherapy. Say for example, a patient has undergone surgery for CA tongue and it turns out to be T3N1M0 lesion. Now this patient is a candidate for adjuvant therapy. It is a stage 3 tumor. So in this case, depending upon the histopathology report and adverse risk factors, we are advising further treatment with radiotherapy. This is post-operative radiotherapy or adjuvant radiotherapy. So this is the meaning of term adjuvant. Another term is neoadjuvant or upfront or anterior. Say for example, a surgeon may feel that first I want to give him pre-operative chemo radiation or pre-operative chemo in order to shrink the tumor and then make it eligible for surgery. So that will be called neoadjuvant therapy. So these are three important terms: definitive treatment, adjuvant radiation, and neoadjuvant therapy. Because sometimes in presentation, we will be talking about these terms. One of the most important thing in dealing with cancer, not only of head and neck, but any part of the body, is staging of the tumor. We should stage the tumor, whether it is stage 1, 2, 3, or 4, and that is done by TNM classification. T stands for tumor, N for nodes, M for metastasis. So this is the
Hello.
latest.
Hello.
Hello.
Sorry, Dr. Sharad, it's been a very nice presentation. Sorry to adjuvant chemotherapy. You talked about if surgeon wants to shrink the tumor, is there any criteria or guidelines, or if suppose resection is the individual criteria for the surgeon? So for
So,
more some specific things, we have to put a neoadjuvant. If we ask for the neoadjuvant, then definitely we have to give for that.
so we will be talking about indications for chemotherapy, whether or not this example I gave just to exemplify or make you understand the meaning of term neoadjuvant, right? By explaining the term neoadjuvant, I definitely do not mean that neoadjuvant is the norm, but just to explain the, okay? So say for example, now we are talking of head and neck cancers
Fine.
and this is TNM classification. So T will stand for the size of the tumor. Nowadays, some new things have come. In earlier TNM classification, the depth of invasion was not taken into account. Nowadays, depth of invasion has become very important. Say, for example, a tumor is less than or equal to 2 centimeter, and depth of invasion is more than 0.5 millimeter, 5 millimeters. Then it becomes T2 and not T1. Similarly, if the depth of infiltration is less than or equal to 10 millimeter with 2 to 4 centimeter size, it will qualify for being called T2. And so on and so forth. So now what I mean to say is that along with tumor size, the depth of invasion has become very important nowadays to categorize into T staging. Similarly, Earlier, extranodal extension was not there in the TNM classification. Nowadays, we all know that extranodal extension is a very sinister sign. Majority of the patients who have extranodal extension or extracapsular spread, they do recur sometime or other. So extranodal extension, as soon as extranodal extension is there, even if it is single node, it becomes N3. It does not qualify for N1. So these are various criteria for assigning N1, N2 or N3 category, but this is a latest development. Similarly, there is one more thing which is not, I'm not able to see at the bottom. Anyway, so I will be talking about these following topics. We will talk about mainly about the cancers of the oral cavity, how multimodality treatment works, a few examples and outcomes of external radiation and brachytherapy case-to-case basis, indications for radical setting treatment, adjuvant setting radiation chemotherapy, indications for concomitant radiochemotherapy. We will talk about the side effects of radiation. We will also talk about newer techniques like the intensity modulated radiotherapy, image guided radiotherapy, SBRT, arc therapy. Then nowadays PET-CT has come up in a big way. So we will also talk about PET-CT based planning and response evaluation. A new approach is coming nowadays. Even if patient has got metastatic disease, especially if it is oligometastasis, even now with oligometastasis nowadays, we can treat with radical intent. We will also talk about survivals. So these are various subsites of oral cavity, you all know. Before starting the treatment, we must do the staging workup. Biopsy is essential. And earlier we used to do a lot of x-rays, but nowadays PET-CT scan has come up in a big way. But when we are not doing PET-CT scan, depending upon the socioeconomic status and patient population in the area, we can do CT scan or MRI scan or X-ray. Hemogram biochemistries are must. The importance of hemogram is very much, say for example, if hemoglobin is low, less than 10, then we try to achieve hemoglobin of at least 10, because oxygenation, proper oxygenation is essential for effectivity of radiotherapy. Similarly, if infection is there, we have to take care of that. Biochemistry, say for example, if kidney functions are deranged, then we may not be able to give concomitant chemotherapy, the cisplatin, which is most commonly used. Similarly, we have to take care of the ECG and echocardiography also, because whenever we give cisplatin along with radiation, cisplatin involves administration of lot of IV fluids, and that leads to congestion of the heart. So before starting patient on weekly cisplatin, we have to ensure a proper cardiac function also. And multidisciplinary consults are required as per the case.
Dr. Sarawat,
Yes, sir.
if a patient is anemic more than HB is more than 10, that is eligible for radiochemotherapy or not?
Yes. We practically take 10 as a cutoff. If patient is having low hemoglobin, then we ask them to get either blood transfusion, because that will increase it fast, and start on some hematinics. But we must ensure that hemoglobin is at least 10.
Okay.
But sometimes practically, when we see patients are not able to afford blood transfusion or practical problems are there, we do start.
Okay, sir. Continue.
So there are two very important pre-malignant lesions of the oral cavity, leukoplakia and erythroplakia. I will not talk about them because that is basically a surgeon's domain, and radiotherapy has no role in the management of these two. But however, I would like to mention that leukoplakia conversion rate into malignancy is 1 to 18%, and erythroplakia conversion rate is almost up to 30%. So whenever such patients come to a dentist or ENT surgeons, they have to be taken care. Now we will talk about one by one about these sites. Coming to the lip, let me again emphasize that in cancers of the oral cavity, surgery is the gold standard. And when I'm talking of radiation, it doesn't mean that radiation, I'm preferring to treat with radiation. I will maintain throughout my presentation that in cancers of the oral cavity, surgery is the gold standard. And whenever radiation is indicated, we will talk about this. My aim is to tell that radiation is also an effective modality and how things are. So role of radiotherapy comes either in adjuvant setting as per the risk factors, depending upon the histopathology report, or in non-surgical cases, wherever patient doesn't want to undergo surgery. There are many patients in practical life, they say, Doctor, surgery to main nahi karwaunga. So those cases we have the second option. And there are many cases where they may not be fit for anesthesia or whatever reasons are there. So radiation will be an option. So as I told you earlier, radiotherapy, if we give in a definitive setting, it will be, the dose will be 70 gray in 35 fractions. We give these 5 days a week except Saturday, Sunday. So in order to deliver 35 fractions, almost 1.5 months is required. Patient has to attend OPD daily. The treatment is of about 8 to 10 minutes per day. Sometimes we give concomitant chemo radiation. We also call it concurrent chemo radiation. So if a patient is having stage 1 or 2, then radiotherapy alone. If a patient is having stage 3 or 4, then concomitant chemo radiation is given. In adjuvant setting, that is post-operative setting, we usually give a dose of 60 gray in 30 fractions. But in cases where there is close margin or positive margin or extracapsular spread, we give 66 gray to that area. Ideally, if margin is positive, we have to do revision surgery, but many a times it may not be feasible. So in those cases, we will boost with radiation. So cancers of the lip are more common as compared to the upper lip. These are some localized lesions of the lower lip, as you can see over here. And they are best treated with surgery. The primary goal, apart from cure, is to maintain oral competence. So if the lesion is small and can be excised without functional sequelae, dysplasias and carcinomas in situ, lesion involving less than 30% of the lip where V-excision and primary closure are excellent. So those cases will be dealt with surgery. Radiotherapy is treatment of choice or maybe preferred in lesions involving commissures, because that may lead to compromise of oral competence. Elective treatment of neck is not required. I will show you the incidence of lymph node involvement. These are some examples treated excellently with surgery, excellent outcome, cosmetic outcome. Nowadays, surgical techniques have improved so much. So disruption of orbicularis oris, that is oral sphincter, can lead to oral incompetence if not properly reconstructed. And there comes the role of radiotherapy. So this is for PG students. What is the estimated risk of lymph node involvement with a T1 or T2 lesion of the oral cavity? So with lip, it is about 5%. With oral tongue, it is about 14% for a T1 lesion and 20 to 30% as the stage increases for about T2 lesions. And others may be between 10 and 20%. So what is the estimated risk of lymph node involvement with a T3 and T4 lesion of oral cancer cavity cancers? So again, I'm wanting to emphasize the fact that we must be aware of T1, T2, T3, T4 lesions, N1, N2, N3 categories and staging. Before embarking on the treatment of the cancer, we must do the TNM staging. So in T3, T4 lesions, if there is a T3, T4 lesion of the lip, then 33% chances of lymph node involvement are there. And in others, there are 33 to 67%. And this is precisely the reason whenever we either operate or give radiation to any primary of the head and neck, apart from the primary tumor, we also address the lymph nodes, neck nodes. Because even if they are not involved, we have to address them because sooner or later they will get involved. So this is an example of CA lip treated with brachytherapy. This was a case with whom we treated with a combination of brachytherapy and external radiation therapy. You can see the interstitial implant over here. And complete response after 3 months. Before and after brachytherapy, patient sent his, he was about to retire, and that was the picture of his retirement farewell. This was a very poor patient. I was at Patna many years back. Their patients, we used to treat patients in just 1,000 or 1,500 rupees. There was no facility of operation theater. We just had a procedure room. So there I used to do a lot of brachytherapy because we have to adapt to the situation. So this patient I treated with brachytherapy and external beam radiotherapy. And this is the picture of the brachytherapy. And patient achieved complete response after completion of treatment. This was an elderly gentleman who had squamous cell carcinoma of the lower lip, extension to the skin of the mentum. So we treated this gentleman with electron beam therapy. So basically we have got two beams, photon beams and electron beam. Photon beam means if we enter from left side, there will be some exit dose of the right side also. The entire area in between that will get irradiated. Whereas in electron beam, we can choose superficial, we can treat superficial tumors. Say for example, I want to treat only 1 centimeter or only 2 centimeter of the tissue. In those cases, we use electron beam, like superficial lesions. So in this patient, you can see the disease has been cured, but some area of cicatrization was left behind. Obviously, he was very elderly man. He failed to come for follow-up after a few months. So we don't know what was the outcome later on. Coming to alveolus, as you can see over here. For early lesions, T1 and T2 surgery alone is a reasonable option. And these are the 5-year survival rates for stage 1 and 2. Elective neck dissection is definitely required from level 1 to 3. I think you people call it modified neck dissection. In alveolus, in a case of CA alveolus, we, in every case for that matter, we closely examine the histopathology report, whether it is T1 or T4 lesion, whether the margins are close or positive, whether there is a presence of perineural invasion or lymphatic or lymphovascular invasion, multiple positive nodes are there or not, extracapsular spread is there or not, because they constitute the indications for post-operative radiotherapy. So whenever a surgeon operates, he sends us for opinion regarding adjuvant radiotherapy or adjuvant chemoradiation. So we have to examine the histopathology report in detail. And that's why I think whenever a surgeon operates upon a patient, they tell the patient that further treatment in form of radiation will be decided after seeing the histopathology report in detail. So upfront, we should never say that this is the only treatment and you will be cured. Later on, treatment may be required, adjuvant treatment. So I've already told this thing that in stage 1 and 2, radiotherapy alone is required, whereas in stage 3 and 4, concomitant chemoradiation is required. There was now regarding this concomitant chemoradiation in definitive setting, a meta-analysis was performed by Pinion et al. Way back in 2009 that established concomitant chemoradiation as a gold standard for advanced disease. So this is a forest plot comparing concomitant chemoradiation versus induction chemotherapy followed by surgery versus adjuvant chemotherapy. Dr. Abhishek had put up this question. So this forest plot is addressing or answering that question. So you can see over here in the concomitant chemoradiation arm, the outcomes were best. Whereas in induction and adjuvant arm, the forest plot is on this side. So it proved that concomitant chemoradiation is the treatment of choice rather than induction chemotherapy or adjuvant chemotherapy in head and neck cancers. So this was the landmark trial which established concomitant chemoradiation as gold standard. This included all stage patients, especially it shows that in stage 3 and 4, the concomitant chemoradiation worked best. It is not required in stage 1 and 2. And across all sites, you can see oral cavity, oropharynx, larynx, hypopharynx, all sites, this concomitant chemoradiation strategy is working. one point I would like to mention here, in this meta-analysis, they observed that in patients aged 71 and above, the benefit of adding chemotherapy went down, partly because if the patient is not able to tolerate both the treatments well, and we may introduce some gaps in between. Introduction of that gap will mitigate the benefit obtained with concomitant chemoradiation. So as a rule of thumb, generally, we tend to treat with concomitant chemoradiation in patients who are 70 and younger. Having said that, there are many patients who may be 75 fit, and there may be some patients who may be 60 unfit. So all those things are there. There is no hard and fast rule, but generalization. Coming to retromolar trigon, early stage retromolar trigon malignancies are equally effectively treated with surgery as well as radiation, with control rates of 92% and 88% respectively. And in stage 3 and 4, of course, combination combined modality treatment is the treatment of choice. Whenever a bone is involved, surgery is 100% preferred. Similarly, here I would like to mention that the lesions tend to be exophytic in nature or endophytic in nature or infiltrative. So whenever the lesion is highly infiltrative, radiation may be slightly less effective. Exophytic lesions, they respond very well to radiation and chemo. In floor of the mouth, we see the nodal metastasis rate. In T1 lesions, it will be about 10% involvement of nodal metastasis, whereas in T4, it will be more than 50%. And similarly, depending on that, the surgery will be there. This floor of the mouth reconstruction, surgery, I will not go into detail of that. In floor of the mouth, we are able to do interstitial implant also. If we are treating the patients with radiation, then we should combine external radiation with interstitial implant. This is just a picture of this. Most of the examples in this which I have shown, these are my personal cases which I have treated. So this is an interstitial implant of floor of the mouth lesion. Very good control rates are mentioned in literature, about 94% for T1 and 0 lesions and 74% for T2 and 0 lesions. Whenever we do brachytherapy for these areas, we introduce lead shields, custom-made lead shields. Otherwise, they will lead to high dose to the alveolus and can result in osteoradionecrosis. So now coming to oral tongue. These are some pictures of the oral tongue lesions. Ulcerative and infiltrative lesions, endophytic lesion. Again, the estimated risk of lymph node involvement with a T1 or T2 lesion of the oral cavity, if it is a lip primary site, almost 5%. Oral tongue is very notorious. Even in T1 lesions, 14%, and 20 to 30% for T2 lesions. So, tongue is a very notorious site for lymphatic involvement or lymphatic spread. So again, which oral CA has greatest propensity for lymph node spread? That is tongue. Can anterior oral tongue cancer involve other lymph nodes without involving level 1 node? Yes. In 1997, Bears had published an article in Head and Neck Journal, and they mentioned that there is almost 13% incidence of involvement of other lymph nodes, even if level 1 node are not involved. And they have got implications on surgery as well as radiation. Like surgeons will operate up to the level 4. As a radiation oncologist, we also treat all cases of CA tongue up to level 4. Which nodal groups drain tip of the tongue? Level 1A. Anterior tongue, level 1B and 2. And posterior tongue, I'm not able to see the lower part of my presentation.
So it is visible to us.
Yeah,
Straight
but
we can see.
I'm not able to see that. Let me just. Anyway.
You can decrease the size.
Anyway, so if a patient is presenting with tongue deviating to the left, which cranial nerve will be involved? That will be left cranial nerve 12, that is hypoglossal nerve. However, there may be one more scenario if there is ankyloglossia. Deep muscles are involved, then patient will not be able to move the tongue and it will be deviating to one side. So that will be T4 lesion and ankyloglossia will be there. Now, what are the factors influencing contralateral lymph node metastasis in oral cancer? So, in tongue, floor of the mouth, and retromolar trigone, as per the tumor site, there is 1% risk of contralateral involvement like that. If distance from midline is more than 1 centimeter, again, crossing less than 1 centimeter and crossing midline more than 1 centimeter, the incidence is increasing. Similarly, as per tumor stage, the incidence of contralateral involvement of lymph node increases. So these things are also to be taken into account while planning for treatment. Well, there are various differential diagnoses for cancers of the oral cavity like the squamous cell carcinoma, minor salivary gland tumors, lymphoma, melanoma, sarcoma, plasmacytoma, amyloblastoma. A patient presents with an oral cancer lesion with ipsilateral ear pain. It may be because of involvement of the auriculotemporal nerve, that is branch of cranial nerve V3. So that is also very important. Commonly, patients come in the OPD telling that मेरे को इस कान में दर्द हो रहा है. So that is because of the nerve entrapment. So TNM I have already discussed. I will skip this. I will allude to this slide later on. This is wrongly fitted over here. So in tongue, coming to the tongue, surgery and radiation are equivalent for very early disease if properly treated. However, if deeply infiltrative lesion is there, it is always better to treat with surgery. So if we are treating a T1 lesion with radiotherapy, brachytherapy in combination with external radiotherapy is done. Why I say in combination with external radiotherapy? Because by brachytherapy, we will be addressing only the primary tumor. Whereas with a combination of external beam radiotherapy, we will also be able to address the neck up to level 4. So this is an example of a patient who has undergone brachytherapy and how the catheters look from outside. I will show you in detail. So this was one gentleman who had T1 lesion of the tongue. So he was not willing for surgery at all, despite consultation with surgeon and all. He said that his profession was such that he was not able to afford hemiglossectomy or whatever. So he said that my profession requires that my tongue remains intact. So he underwent treatment. He's underwent treatment many years back. He's still in contact with me. So he underwent treatment with 5 sessions of HDR brachytherapy and external radiotherapy. You can see over here the lesion is there. So when we take such patients for brachytherapy, I always prefer doing brachytherapy first and then radiotherapy, because if we do external radiotherapy first, it may obscure the primary site. So when we are doing brachytherapy on an intact lesion, we are able to exactly localize. So you can see the lesion over here. We take in operation theater, achieve proper neck extended position, make a tongue tie so that it does not fall back. And this is the position. And we have started putting the brachytherapy catheters over here, one by one. And you can see these are the catheters we placed for this. This is how it looks, and this is how it looks from outside. So after this, patient undergoes planning CT scan, in which we localize the area. Like in this case, you can see we have placed the catheters over here. Here was the T1 lesion, and these are 3D construction views. This is a brachytherapy suite. You can see this is the brachytherapy machine, HDR brachytherapy machine, in which the radioactive isotope is there, that is iridium-192. When the catheters are connected with this to the patient's body, the source will enter the interstitium where the tumor is there, and go back into the machine. When we do weekly review of the patient after completion of treatment, you can see the reactions. This is grade 3 mucositis at the site of radiation. This slide I have put to show the mucositis common terminology criteria grade 1, 2, 3, 4. So grade 1 is just erythema of that area. In grade 2, in picture 1, you can see this is grade 2 mucositis, patchy ulcerations or pseudomembranous. Over here, you can see grade 3 confluent mucositis. So this is how we do the assessment of the toxicity, common terminology criteria. It is called common terminology criteria so that the surgical oncologist, the radiation oncologist, as well as the medical oncologist use the common term to address to the mucositis, because mucositis can also happen because of chemotherapy. So we use a common terminology. So this was weekly review pictures of this patient. You can see where the implant has been put. The dosimetry has been done over here, and the reactions are also exactly at the same site. So this gives us confirmation that the treatment has been delivered at the right site. And such kind of reactions are a source of happiness to the treating doctor, because we have addressed the right site. Later on, during follow-up, these reactions, they do subside. This is another example where we have put a spacer in between the upper and lower teeth so as to increase the distance between the tongue implant and the palate, so the reactions do not come over the palate. So these are some practical things which we do. This was a cosmetic shampoo bottle which I had used. This is a dental shield. We used to place dental shield during the treatment so as to prevent high dose to the alveolus. Otherwise, it can lead to osteoradionecrosis, as you can see over here. This is the planning part of brachytherapy, the brachytherapy console room. After the brachytherapy treatment is over, then is the time to remove the catheters. This patient is undergoing removal of the brachytherapy catheters, has undergone complete removal of the catheters. Another example who developed this grade 3 mucositis, as you can see at the site of implant. He again had a T1 or T2 lesion for which we did brachytherapy and external radiation. And this is the kind of reaction. Now, here I would like to emphasize that this gentleman, he underwent treatment many years back. He was CEO of some big firm, international firm. So he was working in London, and his colleague who used to sit next to him had also undergone the same treatment, brachytherapy. But that patient developed ORN, osteoradionecrosis. But his tongue was completely preserved. So he came to me. He said that I want to undergo this treatment, but I don't want any incidence of osteoradionecrosis. So please take care of that. So we treated him with that. He was a great photographer. He had very high resolution cameras. He still does photography of birds and all. So you can see the clarity of this picture. Clarity. His wife took these pictures of him. So this patient was seen by a surgeon earlier, and surgeon had advised him to undergo surgery. But he refused to undergo surgery and started, he was going radiotherapy. So during radiotherapy, once he was admitted for management of mucositis, so the surgeon who had initially seen him, he saw these reactions and he told him that, देखो मैंने तो आपको पहले ही बोला था कि ये रेडिएशन से जला डालेंगे, अब आप भर्ती हो गए. So this is called vengeance. So such kind of vengeance amongst different specialties, different specialists is not good, because patient comes and tells you everything. If I will tell something to the patient, he will go and tell, or that news will reach the surgeon, and vice versa. So these are side effects. We better call them accompaniments of our treatment. Now, sometimes we see that patients or even our brethren of other specialties, they tell कि भाई जला डालेंगे, radiation से तुमको जला डालेंगे. This is what is meant by जला डालेंगे. You can see this is basically pigmentation of the skin. And you can see over here, the new skin has already started coming. So the skin will become pigmented, but it is a temporary phenomena. every month, the new skin keeps coming. So in about 3 months' time, the entire blackening or discoloration is gone. So these are minor side effects. If we want to achieve big benefit, small side effects are acceptable, and we tell them initially upfront that the kind of mucositis I showed you, the patient मुंह के अंदर छाले पड़ेंगे और skin थोड़ी सी dark होएगी. This you can see over here, but the new skin has already started coming. This was a post-operative case undergoing chemoradiation. So this is the same example. You can see over here, this mucositis has completely disappeared after a few days. Once the patient undergoes brachytherapy, as I told you, it is essential for the patient to undergo external radiotherapy also, because we have to cover the neck nodes also. So this is an example of intensity modulated radiotherapy. You can see by contouring, this is the initial gross tumor volume, which was the site of the tumor. This is the entire tongue to which we have to give some dose. These are the parotids. We draw different structures, the spinal cord, the nodes, etc. So we take CT scan from vertex to D4 vertebra, and in every slice, the radiation oncologist will sit and contour the target volume, that is the primary site, the nodes at risk, and the organs at risk. So you see here, level 4 node has also been demarcated. These are some tools for radiation oncologists. This is called dose volume histogram. So every curve is representing dose to certain area. Say for example, one curve is representing dose to the gross tumor, other may be representing dose to the oral cavity or parotid. So these are tools for us, for radiation oncologists. So in advanced cases of CA tongue, it is always the combination brachytherapy as well as, surgery followed by radiochemotherapy. This is an example of post-operative case. I will skip this. Coming to hard palate. The variety of tumors which come in hard palate are minor salivary gland tumors like the adenoid cystic tumor or mucoepidermoid tumor or adenocarcinomas. Of course, surgery is the gold standard. Sometimes we do brachytherapy, which is called mold brachytherapy. So this is the lesion which we treated with brachytherapy. You can see over here. We have to have a very good rapport with the dentist in the department, in the hospital. So with the help of a dentist, we make specialized mold. So this is a typical example of mold brachytherapy. We draw the shape of the tumor where it is there and put the catheters over here with the help of dentist. This is the tumor impression, and this is some margins along with that which has been given. These are brachytherapy catheters through which the radioactive isotope iridium-192 will come over here and treat. And this is the patient in treatment position. Connected to the brachytherapy machine, the source will come over here, treat and go back. So just a few days after completion of brachytherapy, reactions are definitely there. So surgery, advanced disease, surgery is the treatment of choice. I don't need to go into the details of what kind of surgery and all. And post-operative radiation, as I have already told, close or involved margins, perineural invasion, regional lymph node metastasis, etc. Buccal mucosa, coming to buccal mucosa, small lesions T1 and T2, surgery or radiation. If examples I will show you. This was a lesion involving the anterior commissure. I treated this patient with external radiotherapy as well as brachytherapy. This was the brachytherapy catheters that have been inserted in this area. You can see complete, she also underwent external radiotherapy. Complete response, excellent cosmesis. By showing this example, I do not at all mean that surgery is not the treatment of choice. I just mean to say that radiation is also a very effective modality, especially in lesions involving the anterior commissure. because our brethren, surgical oncologists and ENT surgeons should also be aware of this treatment modality. If we come of advanced diseases, these are some examples of locally advanced tumors, stage 4. Like you can see over here, it has got fungation in the skin. You can see over here the lesion is involving the entire buccal mucosa, upper and lower gingivobuccal sulci reaching up to the RMT. This patient underwent concomitant chemoradiation, and you can see the excellent outcome. She completely had a complete remission after completion of treatment. This was a patient who was referred to me by a surgeon saying that this is inoperable. So the surgeons best know their criteria of inoperability. Similar, these coming 3 or 4 cases are like that only. Again, CA buccal mucosa. These were from Bihar. They have a lot of habit of chewing khani. They keep khani in the cheek. So even the skin is infiltrated. The infratemporal fossa was involved on imaging. Complete response after treatment, you can see. Similarly, you can see complete response after treatment. Stage 4. Normally, people would deem a patient with stage 4 cancer कि भाई घर पे ला के सेवा करो, ज़्यादा कुछ नहीं हो सकता है. If we treat such patients in government hospital, say for example where I did my MD also, if such patients come at a government hospital, we will also treat them with a palliative intent. 20 gray in 5 fractions and that's it. Because the load is so much, we cannot handle. But in private hospital, if these patients come, we treat them with radical intent to cure them. And it is these kind of patients, if we say that if in stage 4, stage 4A, if the cure rate is about 20 to 40%, these are the patients who will get cured. So if the treating physician's attitude is not there, then patient's fate is doomed. Similar example, this patient refused to accept that this is her own photograph, the first one. But then her husband pointed out that Bhagyavan, तुमने देखो उस दिन भी साड़ी वही पहनी थी और आज भी वही पहनी हुई है. And then she agreed and laughed and said, yes, this is my own photograph. Highly infiltrative lesion reaching up to the infratemporal fossa, but she got cured by concomitant chemoradiation. It requires a lot of effort and a lot of side effects. Patient has to undergo a lot of side effects in form of mucositis, skin reactions, and so on and so forth. Dysphagia. Now, this is a example of verrucous carcinoma of the buccal mucosa. You can see the lesion is even crossing the midline and coming to the anterior, opposite anterior commissure, involving the entire GB sulcus, entire lower lip, entire sulcus, entire cheek over here, upper lower gingivobuccal sulci, RMT, and skin. So this was a case which was doomed to, not cure. But then we treated him with concomitant chemoradiation. Verrucous carcinomas, earlier they used to say that they are radio resistant. But we attempted, and to my surprise, while he completed the treatment, he has such an excellent response. You see, it was on the verge of forming orocutaneous fistula. But even this fistula got healed. He had excellent response. So tumor biology is different in different patients. He had a lot of reactions. You can see over here, over the lip, he has got grade 3 reactions. Skin, he had reactions. He had severe dysphagia, but he underwent full treatment. He is in touch with me even now. He underwent treatment in October 13. And recently he has visited my OPD. I took a picture with him. So again, I would tell you that some surgeons might say that these are all operable cases, but it is the perception of individual surgeon. Some surgeons may feel that it is operable, some may feel not operable. And many of them were referred to me by a very famous oncosurgeon. And this is the slide which he gave it to me. He showed me once that knowing when not to operate. This was an article published in British Medical Journal way back in 1999. that good surgeons know how to operate, better ones when to operate, and the best ones when not to. So these cases, he said that they are not good for surgery. But this is a line which I say not for surgeons, but even for us radiation oncologists also. Which cases should be taken for radiation, which should not be taken. It is very easy to operate, it is very easy to give radiation, but we should select the cases correctly. So one should realize perhaps I am the wrong tool for this job. Now, a word about conventional planning, like we used to do in yesteryears, and IMRT, the latest technology. So you can see over here, when we treat patients with conventional planning, if this is the tumor, we are treating the entire area with the same dose of radiation, mostly. As a result of which, the whole area will be subjected to high dose of radiation. Patient will have lot of mucositis, lot of skin reaction, severe dysphagia. We may have to introduce gaps in between treatment. So this was what used to happen in earlier years. The whole area is getting irradiated. Now, and this is the type of dose distribution. The parotids are getting irradiated. This is the tumor. The parotids are getting irradiated. The oral cavity is getting irradiated. The spinal cord is getting irradiated. So entire area is getting irradiated and leading to severe side effects and poor outcomes. Nowadays, we have got intensity modulated radiotherapy. You can see over here, we have been able to spare the parotids bilaterally, spare the oral cavity, spare the spinal cord. Radiation is limited to the target volume only. So much better outcomes, very good tolerance, and we are able to get higher cure rate also. So these are clinical applications of intensity modulated radiotherapy. In conventional, we treat only with left and right, but in IMRT, it is the VMAT type of arc therapy type of thing. The beam will come from all the sides. So these are slides, 2 or 3 slides, which are better understood and for radiation oncologists only, how we prescribe and what precautions we take. So this I will skip. By IMRT, we are able to spare the cochlea also, ipsilateral or bilateral as the case may be. We are able to reduce the incidence of xerostomia. Whenever patient used to receive radiotherapy to head and neck cancer, he used to come later on, डॉक्टर साहब बाकी तो मैं सब ठीक हूँ पर थूक नहीं बनता है, रात को सोने में दिक्कत आती, बार बार पानी पीना पड़ता है, मुंह सूखता रहता है, खाना नहीं खा पाता हूँ. So this is called xerostomia, and with the help of intensity modulated radiotherapy IMRT technique, we are able to decrease the dose to the parotid glands, as I showed you in the earlier slide, and nowadays the incidence of hyposalivation or xerostomia has decreased by a lot. There has been a trial which has proven statistically significant improvement with the use of IMRT in xerostomia. So this is pertaining to that xerostomia only. With the help of IMRT, we have been able to reduce the toxicities. Say, for example, you see this is a conventional radiation and this is the IMRT. Cutaneous reactions have dropped down from 16% to 8%. Mucositis has dropped down from 18% to 0%. 0% is a very highly optimistic, but we do observe these are some results from some public publisher. Xerostomia has come down from 77% to 17%. Osteoradionecrosis, again, in this particular study, it was from 3% to 0%. I won't say any side effect to be 0%. Soft tissue necrosis again. So all these side effects which we used to obtain with conventional radiation have come down substantially with the use of IMRT techniques. These have been able, we have been able to treat with IMRT because of advancement in computerized technology. So nowadays there is a new technique called deep inspiratory breath hold technique. Of course, this is not pertaining to ENT or head and neck cancers, but I just want to make a mention of it because, say, for example, even as ENT surgeons, you come across patients of lung cancer or breast cancer in family, friends, or some patients. You can advise them that DIBH, by especially in left-sided breast cancer, where we are able to spare the heart, or in lung cancer, we are able to spare the heart. As you can see, the This is deep inspiratory breath hold. Patient has been asked to hold the breath in deep inspiratory phase. And it is during this DIBH phase that the machine is switched.
ترتاح يمه.
So now the patient has taken the breath, so the machine has switched off. Similarly, again, when the patient will hold the breath in deep inspiratory phase, the beam will switch on, as you can see, just coming. This was an international patient, Iraqi patient. So
يمه أخذ تنفس طويل.
the interpreter was sitting with us and asking the patient to hold the breath. So now the patient has started deep breathing and held his breath, and now the beam is again on. So this is DIBH technique. Now, in head and neck, there is one technique called adaptive radiotherapy. In this, you see there is a massive neck node. So I will just show you one thing. This patient is undergoing radiotherapy. During radiation, after many fractions, his neck node has subsided. You see over here. That was initial, and this is during treatment. It has shrunk. So at that time, we redo the scan, redo the entire planning, so that the dosimetry which was done initially will be again done. Otherwise, it may lead to unacceptable doses to the spinal cord and parotids and all. So we do, this is achievable by the help of image guided radiotherapy. By image guidance, I mean, when we take up the patient for radiotherapy on day-to-day basis, we do imaging with CT scan with every fraction. And at 20 fractions, say for example, if the tumor has shrunk so much, we will do the whole planning again without charging any extra to the patient. So these are attention to minor details. Nowadays, a new diagnostic modality in form of PET CT scan has come. So this is a PET CT scan machine. We have seen that when we see the tumor on a CT scan vis-a-vis a PET scan, so this was visible on a CT scan, but when we did a PET scan, the entire area was involved. Similarly for nodes also. So PET scan enables us to delineate the tumors better. This is an example of PET CT based planning. We did the planning of the patient in a position in which the patient is treated. And you can see over here, this was the PET scan done after completion of treatment, complete response. As you can see, the shining tumor has completely disappeared in both the sections. So not only for planning, but even for response evaluation, we can do this. Another patient, complete response you can see. So PET CT based planning is an excellent tool nowadays for planning radiation. It improves the quality of treatment by a lot. This is just one example of CA cervix, again, who underwent PET CT based radiotherapy planning and had complete response, as you can see over here. Nowadays, another concept has come of oligometastatic disease. Say, for example, there is a case of head and neck cancer, T3N1, M1. M1 means metastasis. So if a patient has got oligometastasis, means less than 5 lesions in one single organ. Say, for example, if a patient has got 1 or 2 deposits in the lung. So earlier we would treat only with chemotherapy. Once proved to be metastatic disease, we will not go for surgery. We will not go for definitive radiotherapy. We will subject the patient to chemotherapy only. But nowadays, a famous SABR, that is stereotactic ablative radiotherapy COMET trial has come, which has shown that when patients were treated with stereotactic body radiotherapy SBRT to the metastatic deposit along with the primary, the overall survival improved a lot. For PG students, this is a Kaplan-Meier survival curve, which we use to evaluate overall survivals in cancer patients. Whenever in a cancer patient we talk of survival, we talk of 5-year survival, 5-year overall survival, 5-year disease-free survival, and these are done by Kaplan-Meier curves. Earlier, I had shown a forest plot. When we combine many studies together, 10, 15 studies or 100 studies, and we compare them, for that we make a forest plot. But in an individual study, when we see the survival rates, we do it by Kaplan-Meier curve. So this is a Kaplan-Meier curve showing that treating a patient of oligometastatic disease with radical intent again has much better survival outcome as compared to not treating. So another study of Comet 10 has been initiated to further substantiate this observation. This is one example of such patient treated. He had one solitary metastasis in the lung. You can see before and after. We treated him with SBRT to the lung lesion also. Complete disappearance of the lesion along with the primary. So an aggressive approach is required. Now I will show you some examples of brachytherapy. I have already showed you the brachytherapy, that is introduction of catheters within the interstitium of the tumor. This was lip, again lip, floor of the mouth, palate, buccal mucosa. So across all the sites of oral cavity. Now this is one example of Freeberg's applicator. Sometimes what happens after completion of chemoradiation, after 5 months or 6 months or 1 year, patient comes with a nodal recurrence only. So when we do the MRI, on MRI we can see extra nodal extension is there. So we talk to the surgeon. The surgeon takes up in the operation theater, does the neck dissection. We are also there. We apply this Freeberg's applicator over there. So this is basically an intraoperative brachytherapy. So you can see over here, the surgeon has done the neck dissection. We as radiation oncologists have gone there and placed this Freeberg's applicator. Sometimes we have to cancel this procedure, because in this case we cancelled the procedure because it was touching the orbital floor. So we could not have given dose to that area. Otherwise it would have resulted in ORN of the orbital bone. So sometimes, although initially planned, but we have to cancel on the table. So this is the surgery which is being done. And the surgeon is telling us this is the tumor bed. And here we have placed the this is some spacer which has been put because it was closely abutting some blood vessels and nerves. So this patient is taken to the brachytherapy suite. Radiation is being delivered, single fraction, and that's it. So we are able to give additional radiotherapy dose to that area by means of this intraoperative brachytherapy. Of course, for this we have to have very good liaison between the surgeon and radiation oncologist. So brachytherapy, we are talking about brachytherapy. So we have these indications, either definitive brachytherapy standalone, very T1 lesion, say for example, T1 lesion of the lip, we can do with brachytherapy alone, or in combination with external radiotherapy as a boost when we have to cover the neck also. Or it may be done sometimes as adjuvant for positive surgical margins. Of course, positive surgical margins are addressed by revision surgery. But in practical scenario, there may be some situations where we are not able to ask the patient to get a resurgery done, or patient may not be willing. So there are trials addressing to this, and we can do brachytherapy to the positive margin to give a higher dose to that area. So these are some publications regarding that. I will not go into detail. Complications are there with every procedure. No talk of any procedure is complete without talking of complications. So similarly, there are acute complications of brachytherapy. They can be in form of hemorrhage, infection, airway compromise, CL adenitis, and long-term side effects could be there in form of soft tissue necrosis, telangiectasia, rarely ORN. So we have already talked this. Maybe once again I will repeat. Indications of radiotherapy as a definitive is radiation alone in stage 1 and 2. In stage 3 and 4, it is concomitant chemoradiation. Dose is 70 gray and 35 fractions. And when concomitant chemoradiation is there, we add weekly cisplatin, 40 milligram per meter square. Sometimes patient's cardiac function may be compromised. He may not be able to tolerate cisplatin because we have to infuse a lot of fluid when we give cisplatin. It is nephrotoxic. So in those cases, we have got another marker drug like cetuximab or nimotuzumab. In those cases, instead of cisplatin, we may give that. Post-operative treatment, adjuvant treatment, histopathology, T3, T4 lesions, presence of perineural invasion, lymphovascular invasion, multiple positive nodes, presence of extracapsular spread and closed margins. And these two are for concomitant chemoradiation. I'm stressing these things because these are often missed by many of us. Coming to some outcomes. I think it's already 8. So shall we stop over here, because the almost same amount of presentation is left behind. It is 8 a.m., 8:05. So maybe we can take up the rest part in second part. What do you say, sir?
I think we should complete in the next one lecture, because
Yes.
it is a big,
क्योंकि इतना ही और है अभी.
it is a big subject.
Yes.
Dr. Aman, what is your opinion?
Right, sir. We can take up in the next session, sir.
We can put one more lecture, sir, on this subject.
Yes, sir.
So any questions, sir? Any questions from the PGU students, from the faculty regarding so far presentation?
Sir, it was very nice presentation, as you already had a more than 20-year experience of the head and neck oncology in the chemoradiation things. So I just want to ask the clear-cut indication where we can just put the CTRT, like in the CL larynx, if lesion is T3 or if lesion is L4, where the surgeon and the radiation oncologist or the medical oncologist have a debate over that, where we choose the patient, we take the patient for the CTRT or where we have to opt for the surgery. So this is the gray area. I just want you to highlight that part.
Yeah. So although I will be covering on this topic in the next part, but a short answer to this.
Okay.
So we are living in an era of organ preservation. There are many situations where we are able to preserve the organ. And whenever there are indications, say for example, T4A lesion is there, thyroid cartilage is infiltrated, or some other things are also there, definitely radiation is not going to work. The moment thyroid cartilage is infiltrated,
Right, sir.
has to be treated with surgery followed by. I tell such patients कि भाई देखो ये बीमारी आपकी ट्रक के समान है. अगर ये कार होती तो 2 जने धक्का मार सकते हैं, पर ये ट्रक है, इसमें सबको मिलकर धक्का मारना पड़ेगा. पहले सर्जरी करनी ही पड़ेगी और उसके बाद रेडिएशन करना पड़ेगा. So combined modality treatment is the mantra. However, combined modality treatment comes at a cost. Cost not only in terms of money, but in terms of many other things, which I will be alluding in my next session. So in larynx, there are cases which have to undergo surgery. There are cases which can be treated without surgery by chemoradiation. And of course, we talk of 5-year follow-ups, 5-year survivals. Whether the patient is treated with surgery or radiation or both, the chances of recurrence are there. So we cannot say that patient who has been treated with chemoradiation will always recur, or patient who has been treated with surgery will never recur. I will show you the data in next presentation.
Thank you. Thank you so much, sir.
Welcome.
So, Dr. Bhushan, sir, we have 1 or 2 queries in the chat box.
Yes,
So
sir.
if you can convey them to the speaker and we can answer those queries.
Yeah, definitely. When with new RT machines, when can we do the repeat radiotherapy?
Okay. So
Hello?
yes. So we call this re-irradiation. So the first thing that I would like to mention over here is that when a patient treated with chemoradiation or radiation alone recurs, the treatment of choice is surgery. However, if because of whatever reason surgery is not the option, then we can re-irradiate. The selection criteria has to be there for taking patient with re-irradiation. Say for example, we have to respect the dose to the carotid vessels. The combined dose of previous radiation and present radiation, if it is more than 120 gray, then chances of carotid blowout are there. We have to keep that in mind. Sometimes patient's neck is very much indurated, hard, stony-like. Those cases are not fit at all for re-irradiation. So whenever we have to consider for re-irradiation, we have to examine the patient with our own hands, whether the patient is suitable for re-irradiation or not, how much is the mouth opening, what is the induration, whether it is sitting on the carotid vessel Number two. Number three, the cure rates with re-radiation are to the tune of 20 to 30% only. Whereas if we treat with surgery, it will be almost, at least once it will be removed, and with or without chemoradiation further, it may be there. So any recurrence post-radiation has to be treated with surgery. And number
Sir,
three,
is there any time
what is the
limit?
timeline? So
Yeah,
ideally,
exactly.
yeah.
I just want to
Earlier,
know
we
that.
used to say that at least 2 years should have elapsed between the earlier radiation and the new radiation. However, patients with new techniques, doctors are treating at about 1.5 years also. And with the introduction of SBRT, sometimes when very small area has to be treated, we can treat as early as 1 year also. But we should try to keep as much gap as possible.
Okay. Fine. Sir, next question is that, Dr. Sir, is that okay with your questions?
Yes,
I,
yes.
I
So,
could not.
sir, can you just
Yeah.
brief about the role of hemostatic radiotherapy? Because most of the patients, they come in the emergency with the huge ulcerative growth,
Yes.
and we send them for hemostatic radiotherapy. So what actually happens in that?
Yes. So in head and neck cancers, if patient is having hemoptysis or bleeding through mouth or something, I think one of the most important things is refer to surgeon for carotid ligation, opinion regarding carotid
Yeah.
ligation.
External
CS cervix,
carotidization.
in CS cervix, if patient has come with bleeding, they are very sensitive to radiation, and we give hemostatic radiation, large dose in 1 or 2 fractions, and hemostasis may be achieved. But in head and neck cancers, if there is carotid rupture or whatever, then surgery has to be done. I mean, ligation has to be done very infrequently. Hemostatic RT may be able to control the bleeding if it is, because the exophytic or cancerous growth has tendency to bleed. They tend to bleed, they tend to emanate foul smelling dirty discharge, they tend to cause pain. So bleeding is an inherent property of tumors. So if it is just that, we may be able to control bleeding with hemostatic RT, but majority of the times carotid ligation is one thing which I always prefer.
Right, sir.
So one more thing I just want to ask, sir, do you have any experience of intraoperative brachytherapy?
So the case of Freeburg's applicator, 2 or 3 cases which I showed, they were my cases which we had done.
Okay.
That time I was
So,
working at Rajiv Gandhi Cancer Institute. So there we had a very good department with collaboration between the dentists, the surgeons, the brachytherapy facilities. So these Freeburg applicator, they are the intraoperative brachytherapy cases.
okay. What is your experience about it? What is the useful of that? Because intraoperative brachytherapy using means we are leaving the margin positive behind in the bed.
No, I don't think so. See, the margin,
So,
it is basically done because there was extra capsular spread, which was seen on the
okay.
MRI, and the recurrence was there very soon after radiation. So, because of that extra capsular spread, we have given a boost dose. We give only a dose of 8 gray in single fraction. So, that is not a very high dose, but still we do that. So, as to
Okay.
minimize the chances of further recurrence after surgery. So, we are joining hands, the surgeons and the radiation oncologist.
Okay.
Despite that, disease can come back.
Thank you, sir.
Welcome.
Yeah, it is actually disease nature, not only the surgeon or the radiation oncologist. Sometimes it is the notorious disease nature.
The
Yeah.
disease
Thank
is
you,
so
sir. Thank you
unpredictable.
so much for the nice
The disease
discussion.
is so unpredictable. Sometimes even in stage 4, 4A, when we are thinking that patient may not get cured, patient keeps surviving for 10 years, 15 years, and sometimes even T1 lesions, we find that there is a failure within 5 months.
As we can say, miracle happens in the medical field,
Yes.
as in the onco. Yeah, it is. Thank you, sir. Thank you for the nice presentation. You can have, they can ask.
So, Dr. Arjun Das, sir, sir, you are there? Dr. Arjun. So, sir is, sir, please unmute yourself. Sir, any comments from your side?
Hello. Hello.
Yes,
Can you hear me?
Yes, sir, we can hear you. Sir, last comments from your side.
Yeah. Dr. Sharavat, I think it was a wonderful talk on the topic of radiotherapy, basic principle of radiotherapy in head and neck malignancy, in fact. So I go for the residents, in fact, not for the specialists, in fact. Resident means when you explain to the residents that patient having a malignancy has to go for a radiotherapy. In the radiotherapy, you have two types, basically. One is wide field and another is targeted therapy. And in the targeted therapy, of course, you have talked about IMRT, IGRT, VM, volumetric arc radiation therapy, even adaptive radiotherapy you have talked, then SBRT also you have talked about, in fact. So these are targeted therapy, in fact. Now for the resident, I'm asking the questions for the residents. In fact, though you have talked about those, probably they may not be able to understand that. What are the structure which you should preserve or try to maintain the integrity of those so that the patient does not have any side effect, toxicity, or complications?
So if we have got a CA nasopharynx case, there is one very important other structure also, which is optic pathway, optic chiasma and optic nerves. So that also we contour. The tolerance of optic pathways is about 45 to 50 gray. So sometimes we face a very tough situation when the growth is reaching up to the optic pathways, nasopharyngeal growth, and we have to preserve the optic pathways. So that is possible only with the help of IMRT and adaptive approach. We keep shrinking the size. Other structures that we have to preserve while treating a head and neck cancer patient with radiotherapy are the cochlea, bilateral cochlea, the spinal cord, the brainstem, the parotid glands, the submandibular salivary glands, if possible, the oral cavity, the lip, so that the patient does not face severe reactions, lip mucositis. Then there are pharyngeal constrictor muscles, superior constrictor, middle constrictor, and inferior constrictor. So by contouring and giving constraint to the constrictor muscles in cases in which it is feasible, we reduce the incidence of dysphagia. Similarly, dose to the larynx can also be decreased in oropharyngeal malignancies. So these are the main organs at risks. We call them OAR, organs at risks.
Yeah, basically you are talking about the dysphagia aspiration related structures,
Right.
in fact. So that the patient does not have these type of things besides xerostomia and other structures, in fact.
So by contouring these structures, we are trying to prevent blindness by optic pathway reduction, dysphagia, xerostomia, spinal cord toxicity like Le Hermite syndrome, and so on and so forth.
Right, in fact. So after talking about all these, in fact, for the residents, again, I'm asking about any role or indication of proton therapy.
Proton therapy, yes, proton therapy is an emerging modality, and definitely if any particular case scenario where there is a recurrence, a small recurrence, proton therapy will be better as compared to photon therapy because we are able to confine the dose very much, especially in children or in nasopharyngeal recurrences close to the optic pathways. But it is also one of the best and costliest means of causing toxicity. If say for example जरा सी भी डोज इधर उधर हो गई तो लेने के देने पड़ जाएंगे. So abhi it is a very novel therapy, and definitely wherever selected on proper indication, it has got better outcome as compared to photon beam therapy.
Okay. Now I specifically ask about the larynx part. Suppose, for example, in the head and neck, in fact. So what is the exact indication for proton therapy, in fact? Or I give an example, T1 lesion, T1N0 M0. Larynx, one cord.
Yeah. So as of date,
T1A.
yes. So as of date, even if there is a lesion, T1 lesion of vocal cord, right vocal cord, say for example.
Okay.
So we will not treat the right vocal cord alone. We will treat the entire larynx. Now, maybe in future, the indication may come like you treat only the lesion. Say, for example, the lesion is 0.5 by 0.5 or 1 centimeter involving only the one vocal cord, and you have to treat only that. In that case, proton may be an option. But at present, we do not treat just that lesion. We treat the entire larynx.
Entirely, in fact.
Even
So
say, for
because
example, if anterior commissure is involved, then there is a question mark in mind that whether we should address the nodes, because there are some publications which mention that if the commissure is involved, anterior commissure is involved, then the incidence of lymph node involvement may be slightly higher. So whenever I treat a patient of CA larynx T1 with involvement of anterior commissure, that is T1B, then there is a lot of doubt in my mind whether I should cover the adjacent nodes also or not. Theory doesn't mention cover, but there are some papers who have mentioned that there is high incidence of nodal recurrence.
Yeah, I agree on these issues because when you talk about the oral cavity and oropharynx area, these are considered to be the most dangerous area, I can say, difficult to treat cases, in fact, whether to treat, whether not to treat, in fact. In the early period, in fact, we used to take only the primary pathology, not the secondary or the lymph nodes. But now, of course, you have to take those both aspects in that issues, in fact. Now, because lips and other things, if you are talking about, because they are very lymphatic, rich in lymphatics area. The larynx I talked about only because it is not that rich in lymphatics. In fact, that's what I asked about, whether it is an indication for proton therapy or not.
As of now, I won't say that it is an indication for
It
proton
is an
therapy.
indication, okay. In fact,
In future, maybe if we are targeting only the lesion, only one-sided vocal cord, then
yeah,
one of the indication.
in
But
fact,
anyway, there is no one answer to your question, sir. Because the people who are doing proton therapy, they may argue in favor of proton therapy.
definitely anyone who is having that specialization will talk about that only.
Yes.
So
So
I think it's very
definitely
costly
everyone will
also.
be able to, enumerate
Just
plus and minus of every treatment.
justify his own stance, in fact.
Yes.
Because I think in India, there are two centers here where have a proton therapy, in fact. One is in Hyderabad and another is in Bombay.
Yes.
Yeah.
So in future conferences, it may be one of the topic for debates also.
Definitely, in fact. I think, Dr. Sharawat, you have covered all aspects of malignancy of head and neck, in fact. The take-home message
There's some,
So I'm not able to hear anything right
I
now.
think there is some network issue at sir's end. Yeah, sir is back.
So in any case, we will resume from this slide for the next presentation whenever you say, Dr. Ranga.
Sure, sir.
We will plan and we will share you the link also
Yes.
as soon as possible, sir.
Okay.
So, final words from our new president, Dr. Ranga sir, and our new secretary, Dr. Bhushan Patil sir.
And Dr. Sharawat, it was a very wonderful presentation as you gave to the AOI Haryana and the adjacent people of this our Haryana also. And your concept, one picture depicts thousands of words. You prove it. You show many good picture of the brachytherapy. I never understand the brachytherapy in my MS time, but today I understand what is the brachytherapy, sir. You told in a very good manner, sir. And I think it will prove definitely boon to our residents. They are going to appear in the exam, either MS or DNB students, sir. Thank you, sir, for presenting a very wonderful presentation at this platform, sir.
Thank you.
Yeah, Dr. Rawat, I am Dr. Bhushan Patil. I have just taken over as the secretary of Haryana AOI. Our
Welcome.
AOI is different than your AOI, American Oncology Institute and our Association of Otolaryngology of India. I have heard you before also in IMA meetings at Gurgaon, because I am also based in Gurgaon. So it was amazingly presented, the newer concept, special for the a beautiful presentation. And we look forward for part 2 of your presentation. And at the same time, I would also like to thank both our moderators, Dr. Arjun Das and Dr. Bhushan Kathuria, for being there and moderating the session. So, Dr. Raman, I think we can
Yes,
stop
sir.
here.
We can wind up.
We want few words from our Dr. Surinder Singhal.
Surinder Singhal sir is also there, sir. So please unmute yourself. Surinder sir, please unmute yourself, sir. Yes.
Oh, good evening, everybody.
Good evening, sir.
Good evening, sir.
I was a silent spectator today, but I enjoyed the lecture. There were many things which the concept of which was also clear to me today itself. And I think the residents must be benefited with this lecture. And I look forward to the next part.
Sure, sir.
Hello.
Thank you very much. Thank you.
Thank you, sir.
Thank you, sir.
So we can.
Hello.
Yes, sir. So we can wind up the session.
Raman?
Yes, sir. Hello.
या वो बीच में मेरा डिस्कनेक्ट हो गया था.
कोई नहीं सर, कंटिन्यू प्लीज.
अच्छा.
हाँ जी सर,
I think it was a wonderful lecture or discussions. The take-home message for the residents, I can say that whenever the patient comes to you having a malignancy of the head and neck regions, you go for physical examinations, then you take a biopsy and then other investigations. In fact, now, of course, CT, MRI, and then PET scan has become the standards. And then the modality can be combined or it can be single modality. And in the single modality can be radiotherapy itself, straightforward also. So when you send the patient to the radiotherapist department, it's basically a very super specialized departments, but it helps to all departments of the institutions. In fact, we cannot take separately. In fact, so once the radiotherapy or other chemotherapy is given, the patient comes back to you. I'm talking about the resident aspects of ENT. When patient comes back to you, and then when comes back to the follow-up for you only, in fact, and then also you take the case in totality, which we are taking before making a diagnosis. Now, in that case, it's a curative or it was a palliative, in fact. Whatever the situation may be, that you again take the patient into confidence that, okay, if it is in a curative, of course, he has to come for follow-up, he or she has to come for follow-up. But if it is in a palliative, then also again, the patient has to be counseled or reassure in such a way that patient doesn't go deserted. In fact, patients
I think there is network problem.
I think we can wind up today. Yeah.
Yes.
Sure, sir. चलिए, ठीक है, sir. Good evening, sir. And the next session of ours is case presentation from New Medical College. It will be on a nasal mass or AFRS, sir. So we'll update the link and I'll update the date on the groups. Okay, sir. Thank you very much, sir. Thank you everyone for participating.
Dr. Raman.
Anji, sir.
We can plan one more lecture on radiochemotherapy by Dr. Saraut, and after that we should plan for the nasal mask case.
Sure, sir. Sure, sir.
Okay.
Let me also discuss
so that we can complete all of the radiochemotherapy in the head and neck region, and after that we will discuss that case.
No issue, sir. Actually, I'm telling you because from 11 to 13 we have an ENT update at MAMC and then RhinoCon also.
And before that we can.
We have 10 days. We can have one session of radiochemotherapy, because what I've heard is some faculty or the students will also go on vacation. So I don't know they will be participating the online lecture series or not.
We will put the moderator Dr. Arjun and Dr. Bhushan Kathuria on the same topic.
ठीक है.
As advised by Dr. Surinder Singh.
चलिए, sir. Sure, sir. Sure,
okay.
Sir.
Okay. Good night.
Good night, sir.
Good night.
Good night. Good night.